Okay, so welcome back. So yesterday we started with this need that was based on fear with wrong patient errors. And then we went through the engineering to say, can it be done? And so then I wanted to talk very, very briefly about the preclinical validation. So here's the deal. We got these pictures along with these radiographs, and we wanted to see, does this prevent wrong patient errors, right? So what we did was we had 10 radiologists read 20 radiograph pairs each. So there's a new one and there's an old one, and they have to compare the two and interpret it. And they just did it without the photographs. And then they came back a little while later and they looked at the same 20 pairs of radiographs with the photographs to see if they could find any changes. So here's what happened. Initially, when we showed them these two sets of radiographs, this is a patient who they had whacked out a part of his lungs on the top because he had obstructive lung disease, and the treatment for that is to actually reduce the lung volume. So he had lung volume reduction surgery. And the patient we're showing here, you can see all kinds of things. He had a device that assists his left ventricle. He had a pacing device. This part of this is the pacer. And then, they'd cracked open his chest, and he'd had a bypass of his coronary arteries. So here's the problem. We had 4 people look at this, and they all said, oh, patient was getting worse. And the explanation they gave was, well, he came in for some surgery, for lung surgery, and they took out a part of his lung. Then he had a heart attack as a complication of the surgery. He had a heart attack. And then, he had a bypass done. And then he went into heart failure, and they gave him a pacer and a left ventricular assist device. And so these are all these explanations that people were making. And the thing was, there's nothing wrong with it, because this is what radiologists are trained to do. You go from point A to point B, and you come up with an explanation that for why this might have happened. But the real reason was that these were 2 different patients. And then when we showed it to them with the photographs, nobody missed it, right? Nobody mistook these mixed up radiographs, which we simulated, we made these mix-ups. And so you can see here a fat, balding white male who turned into a skinny, young, black male. I mean, examples of Michael Jackson notwithstanding, none of the radiologists said, okay, this is how the white man became a black man. They didn't come up with explanation, but when they were just shown the radiographs, they came up with all these explanations. So this is sort of a busy slide, but really we had 10 readers, and each of these readers found, without the photographs, they found some errors, and with the photographs, they found some other errors. These were the errors that we introduced, and the errors that they did find, there was one person who found 3 errors without the photographs. With the photographs, they actually found 16 out of 25. So the detection rate went up from 12.5% to 64%. So the photographs as an identifier help you find errors, right? And so this is what that table looks, in a chart form looks like. The error detection rate after you introduce the photos really shot up. Now, there was a reason why they were only at 64% and they didn't get to 100%, and that was because some people were actually not looking at the photos. They were studiously avoiding looking at the photos because they thought maybe we were trying to distract them from the radiographs, because we didn't tell them what the object of the study was. So then we went out and we got 5 more readers, and we said, hey, listen, look at the photos. So the instructions we gave them for the study was look at the photos. And again, in this case, we introduced 4 errors into this set of 20 studies. And without even, when they didn't have the radiographs, when they didn't have the photographs, they found 0% of the errors. But when they did have the photographs, their error rate actually went up to 94.4%. Right? They found 16 out of the 18 wrong patient errors that we had introduced. So photos help. Then the question is, well, does it slow us down? And it turned out that the time for interpretation for those 20 radiograph pairs, it was 35 minutes in group 1. After we showed them the photos, it actually dropped to 25 minutes. Group 2 also, there was a drop. When you pull them all together again, there was a drop. So one of the things that when you introduce new technologies, people ask is, well, is it going to slow me down? And in this case, it turned out it was not slowing them down, because they were using some information from the photographs to help them with what was happening with the radiographs. And I'll show you some more examples of why that might happen. So this new thing that we were introducing was not creating extra work. If anything, it was decreasing the amount of work that they would have to do. We did the same study. Actually, we took it to the American Board of Radiology oral exam setting, where they had 90 board examiners, and we made them look at 10 radiographs, either with photographs or without the photographs. And, those people were a little better. They were some of the best radiologists in the country. And so they started with an error rate of, detection rate of 31% without the photos. The minute we gave them the photos again, it improved to 77%. So the photos worked. So this was sort of a pre-clinical evaluation that we had to do before we could even implement it clinically. So I don't see her here, but one of the students last week said, well, what about privacy issues if you're going to take photographs? And here's the answer to that question. Photos are a HIPAA identifier. HIPAA is this act. It's an act of Congress. Basically, it's an act that protects healthcare data. But a photograph, as far as the HIPAA is concerned, is simply a identifier. It's just like your name, your date of birth, your medical record number, or I think you have a PAN number or something. We have a social security number, but that's really what it is. And all of those identifiers are already present within radiograph. So HIPAA doesn't really care if you add a photo, because it's just another identifier. It needs to be in a secure environment, and it is in a secure environment. We keep it in, as I told you, the PACS, which is the picture archiving and communication system, and it is in a secure environment. It's only seen on a need to know basis. So every time you log into PACS and you look at a study, there is a log of who interacted with it. So really, random people can't be looking at these images. And we already obtain explicit consent in the hospital admit forms. In fact, the one we have at UAB says, I consent to photography and recordings as may be needed for the provision of patient care and education purposes. So if we decide that this is what we need in order to prevent errors, or in order to make our diagnosis better, then it is covered in this consent. But having said all of that, I think the question was an appropriate question that the student asked. She said, well, people are going to be concerned about their privacy. So we went ahead and we talked to 500 patients in the Children's Health of Atlanta. So we thought that people are more concerned about their kids' privacy than they're about their own privacy. And so we asked them, are you worried about privacy? And 38% of them said yes, they were worried about privacy. However, when you look at the other questions, do you support taking pictures if it makes doctors better at interpretation? 96% said yes, go ahead and do it. Will you support it if it will prevent mislabeling errors? 97% said yes. And it didn't seem to matter if the patient was slightly sick, or in the emergency room after trauma, or in an intensive care unit when they had all kinds of things sticking out of them, lines and tubes and all kinds of medical apparatus around them. They still didn't care. Most people said, go ahead and take these pictures if it will reduce errors, if it will make the interpretation better, right? So that's an important question. You can't take a new technology and just slap it into any system. You have to ask the right questions and make sure that people are willing to tolerate the technology from different angles. So there were clinical issues that we had to address. So as I said, we spent a fair amount of time on engineering, and I'm going to spend a fair amount of time on commercialization. So it doesn't matter if you have the greatest technology, the coolest technology. It doesn't matter that it can do fantastic things on preclinical validation. And it doesn't matter if you solve some of the clinical issues. What really matters is, will somebody pay for it, right? If nobody wants to pay for it, then this is useless. So one of the lessons that I learned is, being in an institute, being in an academic institution, I have to learn to work with the Office of Technology Transfer. I don't know what you have in Guindy, but you do have to partner with the people who will help you take ideas that you have to the market. And at some point, you may have to get out of there. I mean, sometimes academic institutions have a certain way of looking at things, and they may not see the big picture. So at some point, you need to get out. This is sort of a lesson for me, is at some point you will have to raise money. And I chose to raise money through grants because it doesn't dilute out my equity, my stake in the company. These tend to be grants that basically just give you the money to do the work that you want to do without taking a part of your company. So one grant leads to another. And so, then I went out and tried to be a good business student. I went to business school to try and figure out, well, what does this all mean if I wanted to try and sell it? If I were to build these devices, these cameras, and hook them onto existing radiology equipment, how much would I start losing initially, and how much, where is my break-even point, and where do I start making money, and how much money would I make? And these graphs are things that you kind of do a little bit in a vacuum with a little bit of data that you've generated. And everybody draws these great curves, and within the third year we'd be making a couple of million, and then by year 8, 9, or 10, we'd get up to 40 million. These are like these projections that we started making. And they were grounded in some reality, which is, we went ahead and did the research. We found out how many existing medical imaging devices there were. And it turned out there were between 200 and 300,000 existing imaging devices. And if we were to charge about $3,000 per camera, that was going to be a 600 to 900 million market. And then we said, well, we would then expand to all future medical imaging devices, which is all of the newer devices that would come in. We'd start slapping the cameras on them by working with all of the big equipment vendors. And then we would expand to future medical imaging devices outside, medical devices outside of medical imaging. So if you think about it, all data in the hospital is going to get digitized. Whether you're doing pulse oximetry, or whether you're doing electrocardiograms, ECG, all of this data is going to get digitized at some point. In fact, it already is being digitized. And you have to wonder, how many mistakes are we making? Are we mixing up one patient's data with another patient's data? And how often does this happen? And it turns out it happens very often, even outside radiology. I had a friend whose dad had a heart attack, and he was being taken care of at Duke Medical Center. and he was looking. So his father-in-law was in the Duke Medical Center. So his father-in-law was in the hospital, and he was looking at the monitor in front of him, and he says, "Oh yeah, I'm looking at my monitor, and my monitor says normal sinus rhythm. So I've got a normal heart pattern." And my friend, who's also a physician, he says, "Call your nurse or your doctor and tell them they're looking at the wrong patient's data." Well, how do you know? Well, I already know that you have a disorder of your heart rhythm. You've got atrial fibrillation. And so they are looking at somebody else's data. And sure enough, it was somebody else's data that they were looking at. So this happens a fair amount. So we started looking at all of these, and and you start getting a little giddy. You say, "Oh yes, I'm going to be acquired by a large imaging vendor. I'm going to become the next Jeff Bezos or the next Elon Musk." And so all these numbers start coming into you, start getting really excited. So, it's very uplifting type of a position you get into. So then we started looking for money. We found some grant funding from Georgia State. We got some money from the National Science Foundation. We got some money from NIH and the National and NSF in terms of SBIR, the small business grants. But we also got something called the I-Corps, and I'll come to I-Corps in just a second. So they gave me some money to just go talk to people. And then we had some plans on how much more non-dilutive funding we were going to get and how much we were going to get from angel funders to fund this project. So this was all fine. And remember I said this, we got some money from the I-Corps project. So I want to talk a little bit about what I-Corps is. So they gave us $50,000 to simply fly around the country and talk to 100 people, right? Customer discovery. Who will pay for this technology? Where is it going to be useful? What pain point are you going to solve, right? So we went around the country. We went to the West Coast, the East Coast, the Midwest, the Southeast. We talked to chief executive officers, chief medical officers, chief quality officers. We talked to chairs of radiology. We talked to radiologists. We talked to technologists. We talked to medical students. We talked to nurses. 110 people we talked to around the country. And we asked them, do you care about errors? And the chief medical officers and the chief quality officers of hospitals would say, of course we care about errors. We absolutely care about patient care. We want to make sure that we make no mistakes. Absolutely. Do you see errors in your practice? And they would say, we used to see errors, but in the last 10 years since I became the chief medical officer, we haven't seen any errors. Or in the last 12 years since I've been the chief quality officer, we don't see that many errors at all. So one, they don't want to tell you the errors that they have seen. Two, in many cases, the errors are not brought up to the chief quality officer, the chief medical officer. Somebody makes a mistake, they hide it, they try to fix it at a lower level. But in any case, they don't see the errors. So then I asked them, what will you pay for reducing errors? And then they say, you haven't been listening to me, have you? I just said, I don't see any errors in my practice. Why am I going to pay you to solve a problem that I don't have? So then we went back to the I-Corps instructors. We had to do this every week. We'd talk to a bunch of people, go back with the results. And the instructors would say, you're asking the wrong question. The right question to ask is, what will you pay for? Right? So we went back and talked to the same people again and said, what will you pay for? If you won't pay for errors, what will you pay for? So that's when some of these people, they're very senior people, they're on top of their field. They tell me, look, Srini, here's how it works. There's something called the top line, which is how much money we bring in, that's the revenue. And there's something called the bottom line, which is the profit that we make after you subtract out our costs. That's the bottom line. That's the net. We really care about that bottom line. And there's two ways of increasing the bottom line. One, you increase the revenue, the top line. The problem is that imaging and radiology is already considered the bad boy. We already draw in a lot of money. We pull in a lot of money, the healthcare money. To say that you're going to charge people more to do what you're doing now, that's not going to work. But if you have a technology that will reduce costs, then I will pay for it because that increases our bottom line. So remember, when I was presenting this, I said, when we did those preclinical studies, we found that if you can make people quicker, if the interpretation time per case can be reduced, that decreases costs. That's the amount that what you have to pay to radiologists will be decreased. So they would pay for that. They were not willing to pay for errors. So this is where you have to learn to pivot. We built a technology to prevent wrong patient errors, but nobody wanted to pay to prevent errors because they felt that, remember the pictures that I showed you, they were burying their head in the sand. They were only seeing the tip of the iceberg. They didn't want to dig and see if there were more errors that we could help with. They just didn't want to know about it, but they were willing to pay if we could deliver a technology that would make radiologists faster. So here's the other thing, markets change. They tell you one thing, a few years later, things will change. And what do I mean by that? So we did this I-Core process in 2014 or 2015, and people were not willing to pay for errors at the time. Remember this, I showed you, these are the results from 2009. There were 196 wrong patient errors in 2009 that led to harm. And this was just in one state, in Pennsylvania. In 2017, that actually went up to 262. So around the country, people were recognizing that these errors were happening more often. And then there were more stories that were coming out. So there was this one patient, Albert Hubbard. He got up from his surgery, and the surgeon's name was Ankur Parekh. He was from the motherland too. He was sitting in front of the patient with a god-awful look on his face saying, I made a mistake. I took out the wrong kidney. I shouldn't have taken out your kidney. And Albert Hubbard says, well, what's going on? What happened? Well, it turned out Albert Hubbard had come into the urologist because he had blood in his urine. The urologist said, go get a CT scan of the abdomen. So they got a CT scan of the belly, and on that CT scan, they found the patient had a 7-centimeter tumor in the kidney. And so urologist has come back to the operating room in 10 days. The patient comes back 10 days later. They cut him open, and he takes out the kidney, and he feels the kidney, and he says, this doesn't feel like there's a 7-centimeter tumor in there. But I'm looking at the picture at the scan, and I see the tumor. So he takes out the kidney, sends it to the pathologist. The pathologist looks at it under the microscope and says, I don't see any tumor in here. So they go back and they dig, and they find out that there were 2 Albert Hubbards who were scanned on the same day. And when he was talking to Albert Hubbard 1, he was looking at Albert Hubbard 2's kidney, right? So some of these stories start making it into the lay press, and then people start paying a little more attention. So you have to be pig-headed. The other lesson with commercialization is you have to be pig-headed. Just because the market said one thing, you can't give up if there's a reason for you to stay with your technology. Let's see, Sangeet, do you know what that is, what that picture is on the right?
I think it's a scribble pad kind of thing that I would suggest.
Yeah, so there was something called a Newton device that Apple came up with back in 96 or 97 or something like that. And for some reason, it didn't work. And there were lots of political reasons for it. The CEO at Apple pushed for it. And then when Steve Jobs came back and became the CEO, he killed everything that the previous CEO had done. That was one reason. The other reason was that really, we didn't have the communication infrastructure in place. We didn't have great Wi-Fi. We didn't have great telephone service. And then email was still sort of in its infancy in the 90s. People were using it, but not that much. Texting was not available. Batteries were really not that great. You had to charge this thing every couple of hours. So there were a lot of reasons why this failed, but many of the engineers who worked on it never really gave up. And they came up with this 10 years later, around 2007, 2008, they started bringing out the iPhones and the iPods, and those were successful because by that time, a lot of battery issues were being solved. A lot of the cell phones were actually becoming more prevalent. You could use them. And then, texting was becoming common. So there were all of these other support things that made this device more successful. So, we really have to be thankful that some of the engineers were pig-headed. They never gave up. So we talked about a need based on fear, which was wrong patient errors. We looked at a solution, which was basically taking photographs of patients along with every imaging study. Then we looked at some preclinical validation to say, well, will this work? Then we addressed some privacy issues. We did some commercialization. We talked a little bit about commercialization. And then, I want to talk about now a need based on hope, which is, can you bring in a technology for what people want it for, and at the same time still help with the wrong patient errors? So we introduced the technology, we went ahead and built it, we deployed it clinically. It's been working for the last 4 years at Emory University in Atlanta. And within the first 8,000 studies, this is what we saw. We saw 2 such cases. So this is a portable radiograph. This is another portable radiograph. They're looking for feeding tube placement. This was before, this was after. And you can see the feeding tube sitting in the distal esophagus just before the stomach, and that's fine. But what the radiologist did not notice was there's a breast shadow here, which you don't see on this one. And because we had these photographs clinically, you could see that this was a Black woman and this was a white male. So the photos helped find errors, right? They helped find 2 errors out of the first 8,000 studies that we did. And that's a big number. 2 out of 8,000 is a lot. Again, remember, it should have been 0. But it was also helping with other cases. So here was a knee. The radiographer usually puts a marker, a lead marker saying left or right, but we couldn't see it on this radiograph. It was placed under the left knee folder, but the interpreting radiologist said, well, I don't know if this is right or left knee. But when they looked at the photograph, you could clearly tell that the radiography plate was placed behind the left knee So they didn't have to repeat that exam and that unnecessary radiation to the patient. Right? In fact, you can actually see the marker, the left marker was here, but when they took that radiograph, it got cropped out. And so they only took a part of the knee and they never included that marker in there. So this can help with quality control. It prevents unnecessary additional studies. So here was a study, a radiograph of the abdomen, which was obtained to rule out free air. Free air is what you get if you have a bowel perforation. So you have a gas within your bowel, and if that bowel is perforated, the air leaks out into your abdominal cavity. And what it does is, if you're sitting upright, that air will sit under the diaphragm, just below the lungs, under the diaphragm. It will pool there. So you will see a little bit of air right here. The problem is, you have to be told, the radiologist has to be told that the patient is upright and not lying down. Because if they're lying down, it just goes to the top of the belly and you don't see it on the radiograph. You'll never find it. So a lot of times we just say, well, I don't know if the patient was supine or upright. I can't tell. But in this case, the photograph clearly shows me that the patient was sitting upright. So it actually makes me confidently make a diagnosis that I could not have made without that photograph. So here was a foot radiograph that my musculoskeletal radiologist friend saw, and it had no information. We didn't know if they were looking for a fracture. We didn't know if they were looking for bone infection related to a diabetic foot ulcer, or we didn't know if they were just looking for some other chronic finding like some arthritis. The photo clearly shows that there is an ulcer on the third toe. And so the radiologist becomes much more efficient and say, okay, I'm just going to look at the third toe and see if there is a bone infection related to that diabetic foot ulcer. So making radiologists faster, and so they can actually get the work done faster, which means that they can do more of the work. And here was an example where they were looking for a feeding tube. We don't see the feeding tube. And now we wonder, well, is it coiled up in the lungs somewhere? Is it up in the neck? You know, when they push it down the nose into the stomach, we don't see it. And so sometimes we spend 15, 20 minutes trying to track down the nurse or the physician taking care of the patient just to ask the question, do they have a feeding tube? And most of the time they don't know. By looking at the photograph, we can tell, well, there's nothing going through the nose or mouth, so I don't need to worry about it. I don't need to make this call. So it makes you more efficient. So this is a more positive use of the technology, not just finding errors. I'll skip this one. And then there's a whole bunch of other things that we are planning on doing with it. Stereo vision to get depth information, using infrared cameras so we can actually see even in the dark. So if this wasn't done in a darker room, you may not be able to get the picture very well, but so we're experimenting with IR. We are using thermal cameras to actually get the patient's temperature from a distance, and that actually helps us with our interpretation, our diagnosis, to know that the patient actually has a documented fever. We started doing this with CT scanners and MR scanners now. It's not just with radiography. And we're doing studies to look at how many errors we're actually preventing, how many laterality errors, left-right errors that we are preventing, and then how much is the radiologist more satisfied with their work? Because up to this point, they were simply looking at radiographs as data, and now they get to see a patient. And so every examination is no longer just a case, it is a patient. It could be your mother, your father, your uncle, your daughter. It could be any one of these people. And to be reminded of that is powerful. So we started doing automatic facial recognition so we don't put the burden on the radiologist. we're actually getting audio and video recordings of the patient. So when they're taking the radiograph, we actually ask the patient, hey, why are you here? What's your chief complaint? We're doing some work to see if having photographs actually causes disparities in care. So for example, do I spend more time if the patient is a pretty young woman as opposed to a 90-year-old geezer? Are there differences in the way I look at blacks versus whites? Do I have inherent biases? So it's helping us study these sorts of things, because in the past, the radiograph was an image. Now that we've started introducing this new thing, how does it change what we do? So for all of this, you need to have a culture change. Anytime you introduce a new technology, anytime you do a new system you put into an existing environment, you're going to have to change the way people look and do things. And there's going to be some resistance. So in the past, we did radiology with films. We used to hang films on these view boxes, basically light boxes. We would look at the radiographs, the printed film. And at some point we went digital. And digital was progress, because I could sit in one place and have images piped to me from all over the country, from many different hospitals. It made me more efficient. I didn't have to scroll up and down this panel to get to the right study. I could just do one click of a button and go to the right patient that to the patient's study that I wanted to see. So it made us very, very efficient. But along with that efficiency, we started losing our patients. We started losing the clinicians. We were just sitting in dark rooms, in labs, and having images shipped to us and interpreting them there and just sending out the reports. And we lost all contact with patients. So here's the question people ask. Well, are you going to break down these walls in order to get the patient and the clinician back to interact with them more? And this is where I say, heck no, I'm not going to do that. I built all this efficiency into the system. I'm not going to break it because this technology is making me lose my patient. Instead, what I'm going to do is I'm going to build windows. This is what I call the windows of opportunity. Here's what we're going to do, what we are building now. If I can do FaceTime, same time, Skype, whatever on my cell phone, why can't I do it on a $20,000 workstation that I have where I'm interpreting CT scans, where I'm interpreting MR examinations? Why can't I, with a click of a button, go directly to the patient, talk to the patient, ask the patient directly, what is it that is bothering you, and use that information as I am interpreting the study? Why can't we do that? Right? So it is possible. So you're actually building more technology, because you built the technology, made you efficient, but you noticed that there was a drawback, and you're going to fix that drawback with other technology. So what this means is, for radiologists, they have to start behaving a little differently now. For the last 20 years, they've been sort of sitting in dark rooms, being lab rats. Now they're going to have to leave the comfort of their reading room. They're going to have to be willing to communicate with patients, and they're going to have to start taking charge of the patient. But progress is never swift, never easy. And that was from Marie Curie, who was one of the, I would say, the mothers of radiology. This is somebody you should know. Samreen, who is Robert Noyce? Yeah, she left. Karthik?
Bob Noyce is one of the founders of Intel. So all the...
That's right. That's exactly right. So he was one of the people who essentially started Silicon Valley, right? That whole revolution. He was one of the, and if he had not died, he probably would have would have received the Nobel Prize. He just they don't give Nobel Prizes posthumously. But he was one of those people who made one of those first ships, and he built the whole industry around it, which is, and I really like what he said. This was from the Intel Museum. I went out and took pictures there in the Bay Area. Don't be encumbered by history. Just go off and do something wonderful. That's easy to say, but how does it work? It works if you're optimistic. Optimism is the essential ingredient for innovation. How else can the individual welcome change over security, adventure over staying in safe places? So, you have to take the risks, and you have to take the risks knowing that things will get better. Things always do. So, why am I pig-headed? Why did I stay with this project for over 12 years? I got this idea 12 years ago, and I've stayed with it for 12 years, and finally making this, went through ups and downs, people saying, I'm not going to pay for this, I will not do this, I will not do that. So remember at the beginning, I showed you a letter from a patient's family, the daughter of Jack Kenyon. And I contacted her. I kept that letter for 20 years. I kept looking at that letter. I contacted her and I told her how that letter made a difference in my life. And so she wrote back, I'm slightly disappointed that you're not a physician that goes to the bedside. You have such a gift with people. I'm glad that your project that you're working on will bring you closer to your patients. And that's when it occurred to me. We all do different projects. We pick up a project, we may write a paper, we may do something with it. A couple of years later, we're working on something else. And a couple of years later, we're working on something else. But this one I stuck with for 12 years. And I started thinking, why did I stick with it? And the reasoning became very clear to me. It was because I was an engineer and I quit engineering to go to medicine because I wanted to help people. I became a physician. And then when it came time for picking a residency, picking a specialty, I said, oh, it's a no-brainer. Radiology makes sense. I'm an engineer and there's a lot of engineering we do in radiology. So let me go there. It made sense. But little did I realize that by going into radiology, I was going to start losing my connection with the patient. The reason that I went into medicine, I was going to start losing that over time. And so this is what drives me. This is why I am pig-headed, because this comes from deep inside me. So the lesson that I would tell you is that it doesn't matter if you have ups and downs. It doesn't matter if you have failures along the way. You're never going to give up if something is at your core. If it is something that's really important to you, you're going to come back. It won't matter what the outside world says. So find that passion, right? And stay with it. So let me give you briefly in the next 5 minutes, lessons learned. You guys are just starting. What year are you all in? The third year?
Yes.
What year?
Oh, yes, sir. We're all in third year.
You're on the third year. So you guys are just starting on this path, right? I mean, it's just wonderful. This is at a point where so many things are open to you. You may think you want to go from point A to point B, and it doesn't have to be a straight path. You can zigzag, and you'll eventually get to where you belong. So I would not worry, because it doesn't matter what you do. Sometimes things change. I had friends who for financial reasons, for family reasons, they were forced into certain things. And with much reluctance, they did it. Some friends' parents said, no, you're not leaving Madras, you're going to stay here. And they went out and, they got a job there. And eventually things changed. They eventually got to do exactly what they wanted to do in the city they wanted to work in. So enjoy the journey, right? So you'll eventually get to where you want to be, but you might as well have fun while you're getting to that point. Things will always get better. So I told you, when I was in Guindy, I was very upset, very depressed. What am I doing here? I hated every minute of it. But I got to do everything that I wanted to do. Find your true passion and follow it. So a lot of people are lucky. Some people are lucky. They know exactly what they want to do and they follow that. Some people are not that lucky. They don't really know what they want to do. In many ways, I didn't really know why I wanted to do medicine. My lesson, what I learned from this was, if you don't know what you want to do, if you don't know why you want to do it, don't worry about it. Don't worry if you don't have that burning desire to do something. Maybe you just haven't found it. But what I learned is that will find you. Your passion, your true calling in life, if you don't find it, it will find you, and it will follow you. So, you see some people around and, they're very dedicated. They know exactly what they want to do, and you're envious. And I was envious sometimes. And it doesn't really matter. You will find what you need to be doing in life. Go beyond the technical lessons. Learn about the culture and the environment you're in. So I tried to focus when I was in Guindy. I said, I'm going to be teaching. So I tried to focus on signal processing and, computer architecture and control systems. But learn also about the culture and the environment you're in. I think there was, in my first year, somebody gave a course on industrial psychology, and I didn't pay enough attention to it. And I wish I had, because I think there was a lot that I could have learned from it. It could have made my life a lot easier. So lots of things that you may feel it doesn't impact me. I just have to become an engineer. I just have to be able to push numbers really fast. And I need to be able to build these great circuits or write these great programs. But what are you using this technology for? Who are you going to help with it? How is it going to impact their lives? You need to be able to understand that. You need to be able to work with other people to achieve those goals, to build those products. Last lesson I want to give you is enjoy the value and learning that Guindy is providing you. Again, I said, I hated it. I didn't like it. 30 years later, when I look back, the things that I learned there are still with me, except for that industrial psychology thing, which I had to go back and relearn because I didn't pay enough attention. But there's a lot of subtle learning that we are doing, and those things are going to stay with you for the rest of your life. And I think, Guindy is absolutely a fantastic institution. You may not value it now because, all you can think of is you're looking at it from that one course or that one exam that's bothering you right now. But when you get that perspective and you look back after 30 years, you'll say, man, there was something I learned there, because that's what's feeding me. That's what is putting food on my table for me and for my kids. That's all I have. Thank you for your attention. If you were paying attention, and there's my email address if any of you want to contact me. If you want to talk about grad school or jobs or medicine or doing different projects in bioengineering, biomedical engineering, if you have any interests. So I don't know how long your classes go. Do you do 50 minutes or 1 hour?
It's I mean, typically it's been 1 hour, but it's really the original schedule was only 50 minutes. So 5 minutes before and 5 minutes after was just part of setup and wind down. So
I'm sorry, that was not Karthik. I thought that was a student, Karthik. You didn't see your camera there. I was asking you a question earlier.
Oh, I didn't realize. I'm just the Shanta is hosting this session. I'm just participating on the background just because I was curious.
Yeah. No, that's cool.
Was there a question I missed?
I thought I asked you a question. Did I ask you a question earlier? I was picking
Bob
on
noise, yes. You asked me a question about Bob noise, but otherwise, is there something else I missed?
No, I was hoping to ask the students. So, I mean, of course, you're going to know Bob Nice because you're from it.
Yeah, you mentioned the name, so I thought you wanted me to respond.
No, I just saw the name and I thought there was another student there. So, sorry, I wasn't trying to pick on you there.
Okay. No, I get it.
Yeah. Well, I hope this was useful. Feel free to email me if you have any questions, if there's something you want to talk about technically, non-technically, or whatever. And this was a great opportunity. Thank you for giving me the chance to talk to some Gindi students.
Professor
Thank you,
Srini,
Shanta.
thank you so much for giving your time so generously to the students of CEG. Greatly appreciated. And all the best to continue your quest.
Bye-bye.
Bye.